Good evening, dear Madam Dr. Lalanta Senaratna and my dear colleagues. It is my pleasure to introduce today's presentation, presenter Dr. Ineisha Manawadu. Dr. Ineisha Manawadu is graduated from the University of Ruhuna. She holds diploma in family medicine. Additionally, she has achieved the MCGP certification. Now she is working at Panadura Base Hospital as a registrar in family medicine. Let's extend a warm welcome to Dr. Ineisha as she begins her presentation. Over to you, Ineisha.
Thank you, Jaimini. Can you hear me? Hello?
Yes, Ineisha.
Okay. So good evening, everyone. Dear Madam and my colleagues. Thank you very much for your kind introduction, Dr. Jaimini. Today, I'm going to present my case, which is related to the most common symptom which we encountered in the primary care setting. So let's move to the case first. There's something problem with my slide share.
Can you use the page down?
Okay. Okay, sorry for the delay. This is my case. Mrs. A, 52-year-old lady, presented with 6 weeks history of right side abdominal pain and discomfort, accompanied by dyspepsia and bloating. History of presenting complaint: 6 weeks ago, she was apparently well and she experienced burning abdominal pain and fullness, followed by right lower abdominal pain. Pain was started gradually and it was dull aching pain. Sometimes pain radiated to the back and pain aggravated by movements and relieved by analgesia. Sorry, can you hear me? Hello?
Can hear.
Okay. The The pain was aggravated by movements and relieved by analgesics. Pain score was 5 out of 10 on admission. And additionally, she reported alteration of bowel habits and mild dysuria. She did not complain any fever and perrectal bleeding. So this is a brief history of the abdominal pain. So I would like to ask from you, what are the things presenting with this kind of lower abdominal pain? So can you tell me what are the conditions? Hello? Hello? Can you hear?
It can be GORD and
Yes, GORD.
bowel pathology in right side of the colon,
Okay.
like tumor, and ovarian pathology.
Yes.
PID, pelvic inflammatory disease.
Yeah, pelvic inflammatory disease.
And urinary tract infection, chronic
Yeah.
pyelonephritis.
Yes. Are there any other conditions?
Possibility
Sorry?
of pancreatitis. Pancreatitis.
Okay. Are there any other conditions?
Any appendicular mass or appendicular pathology?
Yeah, it's possible.
TB cecum,
Yeah. Are there any more? Gallbladder diseases? Yeah, we can take it also as a differential diagnosis. So the differential diagnosis, I put a list: irritable bowel syndrome, GORD, urinary tract infection, and pelvic inflammatory disease, an ovarian tumor or ovarian cyst, colitis, appendicular mass, and colonic cancer, uterine fibroid, renal stone, or diverticulitis. Let's move back to the history. So, past medical history, she is a non-hypertensive patient on treatment. She had several episodes of dyspeptic symptoms and managed as GORD. And she is on losartan 50 milligram BD as a drug history. And she has no drug or food allergies. When we talk about her menstrual history, menarche occurred at the age of 10 years and menopause at the age of 51 years. She did not complain of postmenopausal bleeding or vaginal discharges. She did not complain of postmenopausal symptoms such as hot flushes, irritability, or dyspareunia. She used IUCD for contraception and removed it 2 years ago. A family history: there's no family history of breast, colon, or ovarian cancer. She was wife and husband, son. She did not smoke and not consume alcohol. Sleep has not been affected because of this abdominal pain, but her day-to-day activities have been disturbed because it was a chronic pain like 6 weeks. She was worried about her condition and initially she was ignoring it to seeking medical advice because she thought it simple and she requested for investigations to find out the cause. Okay. So with this for these differential diagnosis, but then I move on to the examination. And lungs, her blood pressure was 130 by 80 and the pulse rate was 80 beats per minute.
Can you share the presentation again?
Okay. Can you see now? Can you see?
Yes.
Yes.
Hello.
Yes.
Yes, yes, we can see.
The examination.
Yes.
Examination finding. BMI was 23 and no, she is not pale, not icteric, no supraclavicular or inguinal lymph nodes. There's no bilateral leg swelling. Blood pressure was 130/80, pulse rate 80, lungs clear, no basal crypts. On abdomen and pelvic examination, no hepatomegaly or splenomegaly, and no renal angle tenderness. And there's a right lower abdominal tenderness. And right pelvic mass was present. On pervaginal examination, on bimanual palpation, the adnexial mass was present, and per rectal examination was normal. So with this examination findings and the brief history, so can we narrow down our differential diagnosis now? So can you tell anyone what are the things we can consider as a differential diagnosis now?
Dr. Ineisha, now it can be ovarian tumor
Yeah,
and a pelvic urinary disease.
yes,
Mm,
Endometriosis
yes,
and
and
pelvic
fecal
abscesses.
mass is
yeah.
also
So,
still possible.
yeah. But she did not complain of constipation for a long time. She had time to time constipation with loose stool, and she did not have any fever and no any vaginal discharges. Uh, so we found that there's a pelvic mass in the right side with bimanual palpation also. There's adnexial mass. So investigations, initially she came with UFR, it's normal, ECG normal, and hemoglobin 11.2. Full blood count was normal. The ultrasound scan done in the ward, it's a right ovarian mass, and the mild ascites was found. And CA125 level came as 96, and ascitic fluid aspiration done under ultrasound guided aspiration done, and the malignant cells were present. And CT abdomen and pelvis performed to grading the stage of the disease to find that. So the when we talk about the management, so it's came as the ovarian mass. So then in the ward, the gynecologist involved to breaking the bad news and referred her to the oncology team. The patient and family members were educated about the condition and the treatment options, talked with them, and the surgery was performed after oncology opinion with the consent of the patient. The bilateral salpingo-oophorectomy and hysterectomy was done. Then post-op chemotherapy was planned, and histology report was came as the epithelial ovarian carcinoma, stage 3. The single agent chemotherapy, IV carboplatin, is containing the platinum drugs used as a cycles, and the pain relief also achieved with oral morphine and diamorphine. And now the patient is under oncology follow-up. Now she is in oncology unit for the chemotherapy. So this is the case which I found during my gynecology appointment. So up to now, do you have anything to ask or anything which miss in the history or examination or management? Okay. So let's talk about the conditions of ovary. So the conditions of the ovary, we can divide it into the two types, benign conditions as well as the malignant conditions. So in the benign conditions, mainly the functional ovarian cyst and the benign ovarian cyst and the borderline ovarian cyst. As simply says, The cyst is a collection of a fluid, and the fluid collection, and it's a we can divide it into the functional or the benign or the borderline and malignant ovarian tumor. First, we talk about the functional ovarian cyst. These are the cyst which enlargement of the one or more follicles and which may fail to rupture and associated with anovulatory cycles or maybe fertility drugs or the polycystic ovarian syndrome, endometriosis. So majority of these functional ovarian cysts, these are called follicular cysts, they are asymptomatic. But they can have mild pain, we can observe. But sometimes the patients with functional cyst can present with severe pain because due to rupture or the torsion or the hemorrhage into the cyst. So other cyst is the lutein cyst. So corpus luteum becomes cystic and persists in a functional state for a long period than normal. They present with the short periods of amenorrhea followed by heavier than usual bleeding. Endometrium is secretory and they resolve spontaneously. So the common presentations of the ovarian cancer symptoms, it's a very vague symptoms they present. So because of that, it is very difficult to find out the when presentation, it's very difficult to detect the case because they came with very vague symptoms like fatigue, feeling lethargy, and abdominal pain or pelvic pain, urinary changes like urgency or frequency, and loss of appetite, changes in the bowel habits, abdominal bloating or increase in size, and unexplained weight loss or weight gain. So the assessment of the ovarian cyst, these depend on the diameter of the cyst and the premenstrual or postmenopause state. In premenopausal women, if the cyst is less than 5 centimeter, the guideline says the no follow-up needed. If the cyst is 5 to 7 centimeters, the need routine follow-up, at least 6 months follow-up, 6 monthly, perform ultrasound scan to assess the size of the cyst. And if the cyst is more than 7 centimeter, need urgent gynecology referral, and at this time we have to do the CA 125 level also. So in postmenopausal women, all the cysts should be referred to the urgently because CA 125 level also essential to monitor the condition. So in postmenopausal women, it is the cyst should be assessed initially, and gynecological referral is essential if it is more than if the patient presents with the cyst. And when we talk about the ovarian malignancy, it is one of the most commonest gynecological malignant in female, and it's one of the most common malignant death occur in female, and it accounts, and the ovary is the 4th commonest site fatal malignant disease, and the lifetime risk is 1 in 70. Mean age is 40 and 60 years. The ovarian malignancy is the global problem, and it's the most challenging condition due to difficulty to identify on presentation, because some of the patients have no symptoms, some have very minimal symptoms, and some have very vague symptoms at presentation. So majority of the patients present in very advanced stage of the disease. So because of that, ovarian malignancy identification is very crucial on the presentation. So when we talk about the ovarian tumors mainly classified as primary ovarian tumor and secondary ovarian tumors. The primary ovarian tumors arising from the tissues in the ovary, and there are 4 histological types of primary tumors: surface epithelium tumors, germ cell tumors, gonadal stromal cell tumors, and mixed type of tumors. So I'm not going to talk the histological types very details. The epithelial cell tumors, it's the most common tumor, is epithelial cell tumor. It accounts 90%, and the serous cell tumors are 60 to 80%, and the endometrioid tumors 15 to 20%. Due to lack of the clear symptoms, often they present in very late stage. In the stage 1, if they present, 5-year survival rate is 90 to 95%. And the stage 3C, 5-year survival rate is 20 to 50%. So when we compare the clinical features in malignant tumors and the benign tumors, the risk of malignancies increases with age. Most of the tumors in female, age more than 45 are malignant. The rapidly growth suggestive of malignancy, and the solid, irregular and nodular growths are more likely to be malignant. And fixation is suggestive of malignancy. Ascites is usually malignant, and edema of the lower limbs suggestive of malignancy. So the types of ovarian tumors, the epithelial tumors which begin in a thin layer of tissue that covers the outside of the ovaries. About 90% of ovarian cancers are epithelial tumor. In the stromal tumors which begin in the ovarian tissue that contain hormone producing cells, these tumors are usually diagnosed at an earlier stage than other ovarian tumor. About 7% of ovarian tumors are stromal. Germ cell tumors are rare. These tend to occur in the young woman, which begin in the egg producing cells. There are risk factors for the ovarian cancer. The age, more than 50 years, are more prone to get the risk, and the family history. The family history, there's a gene called BRCA1 and BRCA2 genes present. They have more prone to get the risk of ovarian cancer, and the obesity, endometriosis, infertility drugs, talcum powder and smoking associated with the occurrence of the ovarian cancer. And the etiology, the family history of ovarian cancer, bowel cancer and breast cancer associated with the high chance of getting ovarian cancer, and the age, reproductive history, birth control, infertility or fertility treatment, breast cancer, hormone therapy, obesity and overweight, and gynecological surgery. In the reproductive history, the nulliparity woman can have more chance to get ovarian cancer because they cause the more ovulation in their ovaries. The multiparity, they have less ovulation, and because of that, they can have less chance to get ovarian cancers. The surgical evaluation is important in following conditions. If the malignancy, we suspect a malignancy, and if the CA125 levels in a postmenopausal patient is very high, CA125 level, and the surgical evaluation is important. And the woman at high genetic risk for the ovarian cancer, and the large masses more than 10 centimeter, which are less likely to regress, and they have a higher risk of symptoms and often more difficult to characterize on ultrasound scan. In this condition, surgical evaluation is important. And what are the ultrasound features associated with malignancy? Irregular solid tumor, ascites, at least 4 papillary projections, irregular multilocular solid tumor, more than 10 centimeter, and very strong intramural blood flow. These conditions need surgical assessment. So then we talk about the risk malignancy index. If we suspect the female is having ovarian malignancy, we can calculate the risk malignancy index. So there are 3 characters used to calculate this: ultrasound scan, menopausal state, and the CA125 level. The risk malignancy index is sensitivity is 78% and specificity is 87%. we can give the marks in each character. The ultrasound scan, if multilocular cyst is 0.1, solid area 0.1, ascites, metastasis, and the bilateral, we are giving the score 0.1, and CA 125 level, and premenopausal is 0.1 and postmenopause 0.3. So these three characters multiplied each other, ultrasound scan, menopausal state, and CA 125 multiplied each other, and then we can get the risk malignancy index. So staging of the tumor, there are different ways of staging the cancer. The American Cancer Society uses a staging system. Stage 1 means the cancer cells affect only the ovary or ovaries and have not spread to any other area. Stage 2, the cancer has affected one or both ovaries and also other organs, the pelvis, such as the uterus, fallopian tubes, bladder, or rectum. Stage 3, the cancer affects one or both ovaries and either the lining of the abdomen or lymph nodes in the back of the abdomen. The stage 4, the cancer has spread to other parts of the body outside the peritoneal cavity. This cavity includes the abdomen and the pelvis. Yeah. So the management of the ovarian will require surgery. It depends on the stage, grade of the disease, and wishes of the patient. Surgery is mainly the total hysterectomy, salpingo-oophorectomy, and remove of the omentum, and the remove the lymph nodes also. In early stage, only affected ovarian tubes will removed. The chemotherapy is anti-cancer drugs and cytotoxic drugs are often used because ovarian tumors very sensitive to chemotherapy. Mostly chemotherapy started after surgery, sometimes before surgery, to shrink the lesion. It's called as a neoadjuvant chemotherapy. So the platinum is the drug containing drugs commonly used for the treatment for the ovarian CA, carboplatin and paclitaxel, and radiotherapy is not often used. So after using the chemotherapy, the oncology team assess the treatment response by doing the CA 125 level. And with chemotherapy, CA 125 level should be gradually fall if it is response to the treatment. And assess the treatment response, X-ray, CT, and MRI is important. And the new drug also used, bevacizumab, PARP inhibitors in special situations. The support during and after surgery, malignant ovarian condition is very challenging to the patient as well as to the family. So help the patient to coping with the condition and encourage the family to cope up the situation, counseling, and help to find the supportive groups. So responsibility of primary care physician in managing of these patients with ovarian cancer. Early detection and referral is very important. Early detection, the recognizing the symptoms and the risk assessment and timely referral. So if a patient come with a very vague symptoms, we have to get the good history and the examination, and then the timely referral is needed. And then the coordination of care, specialist coordination. So we have to coordinate the gynecologist and the oncologist, the other people, to get the maximum support to the patient. And the coordination care involving the multidisciplinary approach. And the supportive care, as a primary care physician, we have to give the supportive care to the patient. So patient education, because we should educate the patient and the family. And we have to tell the other options of the treatment and the prognosis, and give the maximum support to them. And the psychosocial support also we have to give as a primary care physician. And the symptoms management. Sometimes when the patients are coming to us while on chemotherapy, they coming with vomiting or diarrhea or constipation, then we have to assess them and manage symptoms accordingly. And the follow-up and monitoring, we have to educate the patient for regular follow-up and monitoring, and we have to encourage them to go for the clinic. And then as a primary care physician, we have to involve in the palliative care and advanced care planning. So I think now is the end of my presentation. So if you have any questions, you can ask.
Ineisha, excuse
Oh,
me. Hello,
oh,
this COCP, is it a risk factor or a protective factor for this ovarian cyst?
it's a combined contraceptive pills are protective
Right.
protective factor,
Yeah, okay.
because it reduce the ovulation, and it
Mhm.
reduce the stimulation of the ovary, and it says as a protective factor.
Right, thank you.
Nisha,
Yes.
it is a good presentation. Actually, when the patient is present to you, what are the red flags you detected in this patient? Was there any red flags?
Actually, this patient came to the ward when I'm doing the gynecology appointment.
Yeah.
Actually, at that time, she came with this abdominal pain, and then and there we examined and found that the right-sided lower mass, abdominal mass. So actually, at that point, we saw the patient. I saw
Yeah.
the patient in the ward. So
I mean,
then, yeah,
this patient can present to us. I mean, in the
as a
as a
primary,
primary care
yeah,
physician,
yeah.
did the patient has any red flag sign you mentioned? I mean,
Uh,
we can miss at the primary care level. No, this is the stage
yeah,
three cancer. But
yeah,
at the she may has gone to several time to primary care physician with dyspeptic symptoms. But in
yes.
your history, did you notice any red flags? I mean, like loss of
Yeah,
weight
irritable
or
bowel syndrome like features. Recently, if a patient get the female more than 50 years of age getting irritable bowel syndrome like features like bloating or abdominal distension and dyspeptic symptoms, it also we can get as a red flag, because recently they have a complaint of this kind of symptoms, and the weight loss and loss of weight loss actually. So I think mainly the irritable bowel syndrome like features in the presentation, the recent development of irritable bowel syndrome like features can consider as a red
red
flag.
flags, no?
Yeah.
Yeah. Other thing, Inisha, CA125 is elevated with this patient, but no, in all the ovarian cancers, it not be elevated. I think.
Yes.
What are the cancers which not elevate CA125? Have you any idea?
Actually, I don't have, I can't say exact answer for that. They said that all the cancers CA125 level is not increased. Sometimes it was
Yeah.
normal. Yeah, it
Yeah.
will be normal. And in normal condition also CA125 will raised. So we can't rely on that CA125. We have to go for the clinical symptoms and the CA125 level and sound scan finding, I think.
Thank you, Ineisha.
Okay.
And also,
It's a
I have
nice
one
presentation.
question. Yeah, I'm Dr. Yoshini. I have one question from the registrar that because this patient you have already diagnosed in the ward and given all the management. and also the palliative care and all these things is okay, good. And the other thing, as a primary care physician, have you go through their family? Is there any family history of CA ovaries in this patient?
No, madam. There's no family history of such. There's no family history of ovarian cancer or breast cancer or colorectal cancer. There's no history of such, madam.
So, as a primary care physician, have you given advice to the patient to go for the family screening? Tell is their sisters and like that. Have you given an advice to them?
Actually, not, madam. I think we have to do that in the future.
Yeah, you have to do it.
Yeah,
Okay,
it's
thank
a
you.
mistake of me because of the word. I think we missed that part. I think in near future we have to do those
BRCA and
assessment.
all this
Yeah,
thing, no?
yes, madam.
It's better if there is a family, if you as a register in family medicine, once you go for the history and if you find that there is a strong family history of ovarian carcinoma in that patient,
Yeah.
so better to refer the patient to the genetic counseling and all these things and find out is there genetic markers are available present in this family. Okay, that is good
Okay,
for the
madam.
future.
Okay. Okay, madam.
Dr. Ineisha, Dr. Indra is here.
Okay. Yes.
Dr. Ineisha, thank you for your presentation. It was nice and very informative and good eye opener. I want to know what happened to the patient. Like, did she went through? What was the follow up and
Now
the
she's
plan?
actually now she's doing well. She's now in the oncology unit, the oncology follow up. She has been given the IV chemotherapy now. Now she's all right actually. So she's
Okay,
follow up at oncology unit now.
okay.
Uh,
Dr. Ineisha, one more question to ask. Like, in oncology unit, the gynecology unit, they are usually treating the disease, not the patient. But as
Yes,
a primary care physician, that we have to take care of the patient as a whole. Did you
yes.
come across any side effects of drugs? What happened? Like, how did you manage it? And maybe too early to ask because it's just diagnosed. I'm just asking whether uh, what what are there things to do like as a primary care physician during the follow up also.
Yeah, during the follow-up, I think they can get a lot of side effects due to drugs like vomiting and loss of appetite and hair loss, those kind of things. So we have to educate the patient as well as the family about the side effects, as well as we can treat them when they come to our primary care setting. Otherwise, during in the ward, already they have given the the to drugs to prevent vomiting and the pain. Those are given in the ward. In the primary care setting, we can give and assess their pain relief and the nutritional state, as well as the the vomiting and constipation, other side effects, I think. So we have to, as a family physician, we have to be uh, carefully assess those things, I think. Dr. Indalal,
Yeah. I got. Thank you very much.
yeah,
And we have to like psychosocial support also.
yeah.
That is also our duty, I think.
Yes, because they are very depressed and very difficult to cope up this situation. So, as a primary care physician, we can give the support to cope up with the situation with the family as well as the patient. So, I think although they are in the ward during our appointments, we can talk to them and talk to the relatives and give our support to them. I think that's good.
And Dr. Nisha, what about this patient? How did she bear it? Like, it's like having a cancer is a like it's end of the story. Like, so how did
Yeah.
she competent?
Yeah.
How did you help her?
Yeah, initially, actually, she was very depressed, but because she's having several episodes of GORD symptoms, initially she ignored the symptoms and she did not take any medical advice. Because of that, she was disappointed because she came little late. So, but think after we explained the options of the treatment options, she's motivate and she come with that she cope up the situation well. I think now she's all right because she has less side effects of these chemotherapy drugs. Now she is doing well in the oncology clinic. I saw the patient once in the clinic. She is now doing well.
Right, okay. Thank you very much.
Okay, thank you.
One more question, Dr. Ineisha.
Yes.
I think this patient was diagnosed in your clinic. How did you perceive about the breaking of bad news? Patient
Sorry.
might not breaking bad news. How was it done in the ward or clinic? Wherever patient may not have thought she is having a cancer, no?
Yeah.
At the
Yes.
diagnosis, how was it done?
Yeah, so it's mainly done by our sir gynecologist in the ward, and actually the sir is took the patient. Actually, initially, sir talked with the relative, her son and her husband, and asked whether they liked they willing to give the bad news to the patient. Actually they said that is it okay that to give the news to her. So then sir talked to her in a very empathetic way, and sir described the situation and the condition and the options of the treatment. And sir, I think sir did it, and we saw that. Sir explained it very well, and the surgery and the options, treatment options, and about the chemotherapy. Sir give all the details to her, and I think she understood that, and she cope up with that.
Thank you, Dr. Ineisha.
Okay. So now the are there any more questions? I think madam is not there. Oh.
I'm listening your
You said that
discussion.
Madam? Yes, madam.
during
Somebody's asking a question. We'll wait for him.
yeah, Ineisha, you said that during the Breaking Bad News, first they asked from the relatives whether the information is given to the patient or not. But what about the correct thing? It should be happening the vice versa. I think we have to ask from the patient whether we are going to give the information to the relatives or not. What do you think about it?
Yeah,
Exactly. That's actually this point, of course, I want to raise. It is,
yes.
this cannot be done. It's an ethical thing, that you cannot divulge any information without getting the permission from the patient, either to the spouse,
Yes.
right? So which is, we are breaching the ethics, the medical ethics. So ideally, we have to the breaking bad news in the sense there's a technique to do that. But whether the patient likes or not, accept it or not, we have to get some information how the capability of the patient to grasp that, right? So that is how we talk about, get some information before you deliver that story to the patient. But if you understand that patient is receptive enough, you can talk about this disease, and if she's willing only, with her permission only, we can talk about that particular, because she first should know that what's going on in her body. Then only, if she's willing, then sometimes if the patient is not receptive, it is of course again your decision. It's a patient's best interest. You can do things, right? Suppose you think the patient is not receptive, it's because of the situation, because of the complication, but you want to do the best for the patient. If you think that you want to get the maximum from the support from the family, yes, of course, right? But the patient is receptive enough, we have to talk with the patient first. And if she's willing, as I think Lakmal highlighted it, is it Lakmal, I suppose, I heard his voice, I suppose. And then we have to do the other, as he mentioned, we can talk about this thing with the family, because it's purely because of to do the best for the patient, either as a psychological support from the family, or like financial support, or the social support, or whatever, right? Because it's you and your disease. Nobody, because it's you. We have to respect their autonomy. We have to maintain the confidentiality, everything, all our medical ethics. I think you can remember we discussed that during even the DFM. I did those lectures. Can you remember that? I suppose you can remember.
Yes, madam.
That's the thing, right? There are, have you mentioned about, I saw it, advanced care plan?
No, madam. Only the word.
Because I saw, because you once the earlier slides of you mentioned about advanced care plan, isn't it?
Yes, madam.
Advanced care planning is a separate section. I think you must know, because it's not really happening in Sri Lanka right now. Because we must have a lot of legal support to do that or conduct it. In other countries, mainly, it's nicely happening in UK, Australia, is nicely happening. The advanced care planning. It's not like you do things for the patients advanced plan means not related to disease. What are the things available for the patients when the patient becomes very complicated, or the sort of the late stage of the disease? Is not advanced care plan in the sense, if the patient is the receptive, the patient has a decision-making power, then the patient can decide what will be my management plan at the end of my life. For instance, if the patient sort of think she does not need any sort of intubation, maybe we say sometimes the patient is in shock. Sometimes we had to do all the management plan according to that situation. Sometimes the patient say, no, I don't need any of those things. Give the correct medications. But if you think that if you want to give NG feed, or when you want to do colostomy, or you want to do some sort of other treatment, so then patient wishes not to do that. So then the patient cannot decide on those things in latter part of the patient is has not enough sort of capability to get the decisions. It's of course cannot be done. that advanced care plan, of course, can be each and every patient when the patient present, whatever the disease, whether the patient is having disease or not, you must have the sort of the right to ask from the doctor, can I get an advanced care plan for my future? Of course, it is, of course, done by the general practitioners in those countries. It's it's a huge story. Fortunately, the College of Palliative Care, of course, is planning to implement, because I'm in the team. We did so much of discussions about that. And it's a difficult task to get the legal support and a lot of things. So currently we are trying to do some sort of a documentation and get so it could be a cabinet to approve a lot of things, right? So it's better to go like anybody. When you when you have some plans to go and practice in those countries, you must know, as a primary care physician, you should know what is advanced care plan, right? That is one thing. And the other thing, Ineisha, whoever, so though the patient, irrespective whether you give the treatment for the patient or not, what are the common complications they might get? The patients with, I'm talking about ovarian CS. What are the common complications? How they die? What are the common complications? Usually they present several times having this. What is the most, like, if you know, what are the most common presentations, either with or without treatment? Of course, with treatment, this presentation a little bit late, like very late presentation. But whatever, any idea about that? Complications?
Sepsis, ma'am?
Sepsis. Why they get sepsis then?
Due to bone marrow suppression caused by the chemotherapeutic agents.
Yeah, it's a little bit of a yeah. Before that, what can happen?
Torsions.
Torsions.
The recurrence of the disease, madam, the relapses.
So what relapses you are talking about? Suppose it's now disseminated. That's how it happens, right?
Yeah.
So it's an ovary. So it's very likely get disseminated to where? To which part of the body?
Bones.
Brain?
When? Where is this situated in the ovary? Which part in the body?
Liver, madam.
Liver, okay.
Secondary.
Liver secondary is okay, fine. It's a huge story then. Okay, right. With this liver secondaries, we'll say, so what are the common structures, like sort of the patient, like what, if you want to examine the patient, which, there are systems, cardiovascular, respiratory, abdomen, which system you want to examine?
It will spread to the lungs and coming with a shortness of breath.
Yeah, the patient comes with short of breath. It's because of lungs and mainly due to what, Prasad?
Embolization.
Ascites is very common, like they come, it's repeated, because how much they sometimes, if the patient comes with ascites, what the oncology people do?
Aspiration.
Yeah, aspirations. What if you work in an oncology unit, how often they come for the aspirations then? Later part of the thing.
Twice per week, like, madam?
Yeah, that's so. Is it a very comfortable thing then?
No.
No. They come to you with difficulty in breathing. Remember, it's not only the lungs. Look at the abdomen. Because it's bowel obstruction, ascites, a lot of things. So that is how, because we are not treating those like patients with CAs or whatever, but we are there to deliver shared care or the supportive care for to not only to the patient, to oncologists, because we are the people who have to, like, not to the diagnosis of the disease, to manage complications and keep the patient comfortable, right? This is your duty, not anybody's duty. Because of that, you better like read. I mean, y'all, not to Ineisha I'm talking about. It's for y'all. Think if the patient, because it's a very like sort of big, like very fast spreading sometimes, you know, like not sort of difficult to manage sometimes, because it's very later, I mean, diagnosis is very late. And because of those things, the complications are very common after even the diagnosis, after even initiating treatments. Because of that, you should know what are the complications and how the patients will come to you, and what are the things you should do, and what are the systems you should examine, and what are the ways of like giving some support to the patient. So these are, of course, it's a separate section to talk about. Even as a CQ, we can talk about those things. Even as a long case, we can discuss about. So after these, all the initial management, the patient had undergone for a surgery, and then all the chemotherapy started. Now patient presented with short of breath. So then after that, we can say, discuss about the management plan. Likewise, so for that, you should know all these things. I think just is an eye opener for you all. But anyhow, Ineisha is a good presenter because you did a lot of theory part. It's good. But for the completeness, I must say these things, of course, we should do. Right? So it's not only for you, everybody. You please refer some books, refer some documents, go to and have some sort of, there are a lot of things available in the net. You can go for the good ones, the guidelines, you can go for the things and just check what are the things you can do for the patients. Okay, I think it's time from 10:30, 1 hour gone.
Thank you very much, madam, for your kind support. Thank you very much, madam.
Hello.
Hello.
Hello, madam.
I think madam
Left.
left.
No, I want to ask madam, this is regarding breaking bad news. Is madam there?
Yes, I am there.
Madam, in case of breaking bad news, if the family members telling that don't break this to the patient, what can we do, madam?
Why you want to tell all this to the family first?
In case if patient family member came to collect the histology report, then we have to divulge the things to the family members.
No. There's no thing like we have to. We just issue the report. That's it.
Okay.
Because it's in Sri Lanka, the practice is totally different. Right? It's not the ideal way. Because why the advanced care plan is also there. The patient has the right to say, look here, don't do this, don't do that. It's my life. Okay, so then it's, like that is why I told at the beginning, we must have a lot of things, even the people, the way look at it, the cultural and lot of things are there. And it's a very difficult things to start here. But
Yes.
anyway, we are trying our best. We are trying our best to do that because, of course, some people, they say, look here, I want to live peacefully. Please don't insert this tube, that tube, and don't give like, if the patient sort of, even sometimes they don't like the cardio versions or whatever. They don't like it. They say, don't do that. Please let me go. Right? So actually it's important, because if you think very deeply, ultimately the patient thinks, I must have a very peaceful thoughts at the end of my life. If somebody comes and poke into all these things and doing all the nonsense, right? They cannot have their peace in their mind. So I'm totally with the ACP, Advanced Care Plan. I want it. I think it's the right of the patient. I don't know about the others, because you have to decide. I cannot decide on these things at the end of my life. Like when I was actually doing the foreign training in 2014, when I came here, actually I had a chat with some people, even the legal people. Why can't we implement here in Sri Lanka? Because I really like it. Because nobody can decide on your life. It's you and your life. If I think, oh, I want to go very peacefully, that's it. Right? It's very difficult to convince people in Sri Lanka. It's because all the time there is no sort of you don't have your right to talk about yourself even. Somebody is trying to tell you, trying to sort of plan your decision, plan your life. Do these, don't do these, do's and don'ts all the time. That's the problem. Because you and your life, that's it. I don't know whether you agree with me. I really like it. And we want to somehow commence this ACP here in Sri Lanka. Okay.
Thank you.
Thank
Did I
you,
answer
madam.
the question, Finance? The rest of the thing I'll teach you on Monday.
Okay, thank
Thank you
you.
very much, madam.
Okay, then.
Thank you very much, madam, for your support. And shall we stop?